Hi, hi, Swami. How are you? We can't hear you. You're muted.
Yeah, hi Mayank, how are you?
Yeah, good thanks. Good thanks. So I'll just introduce you to everyone, but I'll just um, ask Henry, are you happy we start? And, and Imesh, are you okay we start? Or do you want
Yeah,
to
no,
wait?
it's 4 minutes past. Hopefully, people will join.
Okay. All right, great. So, um, my name is Mayank, and I will try and chair this session. I think Santosh is scrubbed for a transplantation right now, so he will join a bit later. But I first want to introduce my friend and our guest speaker from India. He is Dr. Swaminathan. He works as a director and head of liver and multi-organ transplant surgery in Kaveri Hospital in various places in South India, mainly Chennai, Trichy, Salem. He is an advanced robotic and laparoscopic surgeon also. He does a lot of upper GI work robotically. He was in Adelaide, I think about 20 years back, Swami, if I'm not mistaken,
Yeah, 2012. Uh,
2012.
yeah,
Worked with Chris in the unit in Adelaide. So um, I'll just invite Swami if you want to start your presentation and give a brief introduction about yourself. That'll be very nice.
sure. Mayank, I'll just share the. Uh,
Oops.
oops, did I do something? Wait a second.
Yeah, yeah, we can see you.
You can see the screen. Yeah,
Yeah,
see the presentation. Yeah.
yeah.
All right. Thank you, Mayank. Thank you. Thank you for having me for this talk. It's in fact an honor to share the experience of the role of robotics in liver and kidney transplant. What we do is our unit is basically a multi-organ transplant unit, and also we do some advanced robotic GA-HPV procedures. And we have a X system with us for the last couple of 3 years. We've been doing robotics in kidney and liver transplantation. So my talk today will be mostly covering on kidney transplants and a little bit on liver transplant, mostly the robotic donor hepatectomy for live donor liver transplant. So I'll restrict most of my time on to the kidney because that's more pertinent to Australia, whereas a live donor is more of an Asian thing. So shall I proceed with the talk?
Yeah,
Are we
please. No, get going, because it is being recorded to
okay?
let you know, Swami, and it'll be shared with the society.
Okay. So, as we all know, the single greatest surgical innovation in the past 2 decades would be the robotic surgery. We surgeons, we all love to utilize robotic surgery in every field of surgery. It has got its own advantages, just like any other laparoscopic procedure. Incision-related complications are lower, early return to daily activity, excellent cosmesis with less pain, and it's a luxury for the surgeons to use robotics when compared to laparoscopy. And now, in the last couple of decades, slowly we've been using robotics in the field of transplant surgery, which requires, in fact, more accuracy, precision, and effectiveness, particularly in procedures like kidney transplant, donor hepatectomies, and in fact, there are some recent reports on totally robotic liver transplantation from a few units in Korea. So, despite the concern about the ischemic time and the complexity of the surgical procedure, robotic is slowly gaining popularity in the field of transplant. Particularly, it's finding its place in obese patients in kidney transplant and in donor hepatectomy procedures. So next few slides, I'll talk about robotic-assisted kidney transplants, how it evolved, what is the practice pattern at the moment, what's the penetration, the outcome of the current evidence, how to set up or to transition to a robotic kidney transplant program from an open kidney transplant program, and a little bit about robotic-assisted donor hepatectomy in LDLT. We all know that lab donor nephrectomy has become a standard of care in kidney transplantation, and transplant surgeons been always have this urge to apply minimally invasive options for kidney transplant, and there were initially a few reports of laparoscopic kidney transplant. In fact, one of the largest series came from Pranjal Modi's unit in 2013. With 72 cases of laparoscopic kidney transplantation. Yet, the liver laparoscopic kidney transplant did not receive widespread adoption, mainly because of the technical challenges involved, requiring surgeons to have some advanced laparoscopic suturing skills, complex instrument handling, and particularly when things don't go well, it's very hard to manage laparoscopically. We had to wait, and when robotics came into practice, that really gave a breakthrough for kidney transplant. Defner's group, Barnabas, in fact, did the first series of 20 cases, unpublished though. They showed a median operating time of 262 minutes with 58 minutes for anastomosis. And creatinine at 1 week, 1 month, and 3 months were 1.3 to 1.6, which is comparable to an open kidney transplant. This actually demonstrated the technical feasibility with acceptable outcomes. And then subsequently, Gallinati group, group from Italy, the first published experience of RAKT, and that paved way for more centers to take up robotic kidney transplant. Several techniques has been developed, right from positioning to docking, how to insert the kidney, whether through a periumbilical incision or a phalansteal incision, midline incision. So many techniques has been described. That actually led to standardization, a requirement to standardize RAKT. So Mani Menon from Detroit, their group.
The next stop is Marion. A light here for marketplace light.
Group Mani Menon and his group, along with Rajesh Alawat and Modi group, they developed what is called as Verticuti Medanta technique to standardize robotic kidney transplant using robust evaluation for safety and effectiveness. This is achieved through adherence to the ideal framework, which is innovation, development, exploration, assessment, long-term study framework. With that, they gave a stepwise approach or technique for robotic kidney transplant. And then subsequently, the same group went on to do a phase 2A study with the Verticuti Medanta technique, and published about 65 cases of robotic-assisted kidney transplant. What they used is to start with a regional hypothermia, where they constantly pour ice slush over the kidney while doing the anastomosis to maintain the temperature between 18 to 20 degrees. So this allows them to perform the vascular anastomosis robotically. Usually with the robotic kidney transplants, anastomosis takes a bit longer than the open procedure, on an average somewhere between 45 to 50 minutes for most of the units. So these are the outcomes. There are several published large numbers. The most recent one is, just move to the next slide. The initial studies came in 2013 and 15 with Oberholzer group. They published 39 RAKT in obese patients with a average BMI of 42 plus or minus 7. And they compared with obese 28 open kidney transplant, and found that the surgical site infection rates were almost negligible or nil when compared to open kidney transplant, and the patient and graft survival were comparable between the two groups. Similarly, Akshay Sood, the Medanta group, again went on to publish 67 RAKT using the Verticuti Medanta technique. They showed no conversion to open surgery. The mean console time, warm ischemia time, rewarming time, they were all comparable to open kidney transplant, with no cases of vascular complications, strictures, or urine leaks. However, a European multi-center trial in 2017, which included 120 patients from 8 institutes, showed about 4 cases of DGF. Of course, that was a mix of case with both cadaver and live donor, and 5 re-explorations, no wound complications. They concluded that the short-term graft survival is comparable to open kidney transplant. The largest series is 10-year experience with a single center, 239 RAKTs with a conversion rate of about 3.9%. The median operating time was 4.8 hours, with the warm ischemia time was as low as 45 minutes. And the wound complications rate 3.8 compared to 22% in open kidney transplant. And the 1 and 3 year graft survival reported was 98% and 93% with the RAKT group, which is comparable to the open kidney transplant group. I'm gonna skip this. So if you look at the penetration rate of RAKT in kidney transplant practice, there seems to be a gradually, initially there was more of this robotic kidney transplant was applied for cadaver transplants, but then the trend is changing from 2017 till now. You can see that there is an increasing trend of RAKT in live donor kidney transplant setting, and it's being less utilized in cadaver settings. The overall the application of robotics is somewhere in the range of 11 to 12% across most of the European North American centers. I'm just going to show a small video before we just a 1-minute video of robotic kidney transplant. This is basically what we do is we make a small fan and steel incision. Before making the fan and steel incision, we get the iliac artery and iliac vein. It's fantastic to do it with robotics because of the instrumentation. It gives such a comfort for the surgeons. Once the iliac artery and vessels are ligated, then we make a small extraperitoneal pocket where the kidney goes in after implantation. Initially, we used to do an L-shaped flap, but now I do a complete drop down of the flap, just like a robotic hernia repair. So that's a vein anastomosis is done by with a 6-0 Gore-Tex suture. On my left hand, what I have is called as a black diamond forceps, which is a very fine forceps, like a fine DeBakey's forceps, and we use we also have a robotic pot scissors. That's what I'm using to do an arteriotomy. Nowadays, we have a robotic punch, which is specifically designed for robotic kidney transplant. We make a nice punch and we can do the arterial anastomosis. Again, it's done with the 6-0 Gore-Tex. And usually the anastomosis takes about 30 to 40 minutes. But because the kidney is kept continuously flushed with ice, and that's after reperfusion, you can see urine immediately on table, and the kidney is then placed in the extraperitoneal pocket and secured with a few hemolocks. As of now, I'm still doing the ureteric anastomosis as extracorporeal through the fan and steel incision made for inserting the graft kidney that relieves the pneumoperitoneum pressure over the graft so that the graft gets perfused well. So we thought we'll first do that technique for the first 20-30 cases. So how we transition from open to robotic, basically we looked into our first 21 cases that we did from June 2023 to 24. We looked into the stepwise progression, the technical training of the team, instrument usage, in-depth preoperative planning. We did an SOP of the surgical standardization of surgical steps, including positioning and utilization of regional hypothermia, because that keeps the temperature of the kidney so that we can take a little extra time to do the vascular anastomosis. And we also analyze the duration of surgery, warm ischemia time, immediate creatinine decline, and duration of hospital stay, pain score, and wound complications. We specifically select donors, younger donors with a good GFR with the DTPA, single renal vessel, and single ureter. For cadaveric kidneys, we selected only standard criteria donors with an anticipated cold ischemia time of less than 8 hours. Recipients, we selected patients without any cardiopulmonary comorbidities because we need to position the patient in a steep Trendelenburg position for a prolonged period of time, almost like 4 hours, 4 to 5 hours. In BMI, we kept for the initial 20 cases between 32 to 40 without any previous major operations, abdominal operations. What we found was we had an average warm ischemia time of about 57 minutes and a vascular anastomosis time of about 42 minutes. Despite the relatively prolonged warm ischemia time, we didn't find any adverse outcome on the graft. There was only one delayed graft function, that was with the deceased donor renal transplant. Our average post-operative serum creatinine at day 4 was 1.3 and at 1 month was 1.1, which is comparable to open kidney transplant. We had one patient who underwent re-exploration because of page kidney. There were no wound complications, and in fact, the pain score was very low. Average hospital stay for our patients about 4.2 days, and the BMI was 35.7. The regional hypothermia actually helps us to slowly do the anastomosis, even though the warm ischemia time is close to 1 hour. We really didn't have any issues in the post-operative creatinine decline. So how to set up a RAKT program? What did we do to improve efficiency and outcome? We identified the team members. It's the same set of team members who do kidney transplants, robotic kidney transplants, surgeon, assistant surgeon, scrub nurse, everyone is the same set, including the anesthetist. We implemented regional hypothermia, where the bedside surgeon constantly pours ice slush with a Cumis syringe on the kidney. We also create a small ice pack and drop it through the phalansteal incision. We use a gel point, and through the gel point, the assistant surgeon constantly drops ice slush. Of course, it floods the field a little bit, but then assistant surgeon has to be adept to suck the fluid out constantly. And we had developed standard operating procedures and a timesheet. I'll show you. Who can adopt a RAKT? Medium to high volume kidney transplant centers who does about 70 to 100 transplants. Our average annual transplant numbers somewhere about 80 to 90. So surgeons with experience in open kidney transplant and robotic surgery, they can bring those skills together. Of course, we spent a lot of hours doing vascular anastomosis practice with wet lab. We should have dedicated team members with appropriate training. Regional hypothermia has been really important in the first few cases for us, because first few cases we had warm ischemia time exceeding 1 hour, where the ice slush and the regional hypothermia kept the kidney really cold. And in fact, because the abdomen is closed, there is no heat exchange. We kept the CO2 flow at a slightly lower rate, between 10 to 12. The issues we faced were patient hypothermia, increased risk of lactic acidosis and flooding of the field. So we started using underbody warmer, bear huggers, and again, constant suction. This is a standard operating protocol that we have. We wrote down all the stepwise, everything was written down. And we have an RAKT timesheet where we document every step. And then over the last 20 cases, we've gradually improved from an operating time of 5.5, 6 hours to almost 4 hours now. That's a difference in the scar. We can see such a wonderful difference in the cosmosis. We usually make a phalansteal incision and insert a gel point there, and that's where we drop the kidney. So while open kidney transplant is still a standard method, definitely RAKT is advantageous in terms of lesser pain and non-inferior outcome to open surgery. It's particularly useful in obese recipients in terms of postoperative pain, surgical site infections, and incision hernia. However, the disadvantages are increased cost, availability of expertise, and the initial learning curve. Initial mentoring aids to understand the common pitfalls. Adopting techniques from high volume centers further helps in decreasing the docking, console time, and undocking time. We in fact had first 2 cases, we had proctors coming in for the procedure. I'll move on to robotic living donor hepatectomy for live donor liver transplant. So why are we talking about minimally invasive donor hepatectomy? Because open donor hepatectomy carries a morbidity of almost 20 to 40%. And most of the morbidity is associated with the incisional pain, surgical site infection, disfiguring scar, hernia, and adhesive intestinal obstruction. First application of minimally invasive liver surgery in the field of living donor liver transplant occurred in Paris by Cherokee Group, and that resulted in the sentinel proof of concept for minimally invasive donor hepatectomy. They did donor left lateral section for pediatric liver transplants. So what are the advantages of laparoscopic donor or advantages, or what are the published data we have for laparoscopic donor hepatectomy is the Troisi group. They compared the minimally invasive and open living donor hepatectomy, which is systematic review and meta-analysis. They showed that the overall morbidity in laparoscopic group was significantly low, and wound complications rates were significantly low when compared to open group. And liver-related complications such as bile leak and stricture formations were indistinguishable between the two groups. In fact, the major concern with the minimally invasive donor hepatectomy is biliary complication rates in the recipient and bleeding and biliary complications in the donor. However, David Kwang's group from Korea, they showed that the median hospital stay was significantly shorter in laparoscopic group, and the complication rates between the donor and the recipients were comparable. Particularly the recipient vascular and biliary complication rates is not significantly different from the open procedures, and this resulted in equal and 30-day graft and patient survival. Other groups from Korea, most of the data from the laparoscopic donor hepatectomy came from Korea and Japan. All of them showed, although few groups showed slightly increased incidence of biliary complication in the recipient group, in the laparoscopic group. But then most of the groups went on to, with more experience gained, the biliary complication rates came down significantly. There was a consensus conference in 2022 to formulate the status and future role of minimally invasive donor hepatectomy surgery, and that was published in 2029 in the Annals of Surgery. And the group actually concluded that minimally invasive surgery has less pain, less blood loss, shorter hospital stay, and concluded that no increase in overall complication rate was noted in the initial minimally invasive donor hepatectomy series in comparison to open donor hepatectomy cases. So although pure laparoscopic donor hepatectomy has gained some popularity in Korea and Japan, the adoption has been a little sluggish in the rest of the world. Challenges being it's a taxing economics, suboptimal visualization, it requires intracorporeal suturing skills, and all coupled together. It's a demanding and a very long and lengthy procedure. The donor hepatectomy operation itself is a very lengthy and demanding procedure. So to overcome all these things, the robotic has come into play. The robotic platform has addressed all these challenges more efficiently. Steady and superior visualization with 10x magnification, optimal ergonomics with tremor-free instrumental movements, precise dissection capabilities, easier and more expeditious suturing abilities. All these things help the surgeon to favor robotic over laparoscopy. Now, robotic donor hepatectomy is slowly catching up. What are the disadvantages? Yes, there is no QSAR. We still use harmonics with an open-closed jaw technique. Nowadays, we started doing what is called as a robotoclysis, which is very similar to an open cheliclysis technique. Use a bipolar to just do the parenchymal transection. It works fantastic. And there's always been a concern if there is any torrential bleeding, then rapid conversion becomes difficult. But then bleeding has never been a problem because of the wonderful 3D visualization and magnification. Along with that, meticulous and accurate dissection with robotics helps to prevent bleeding. And in fact, even if minor bleed happens from a segment 5 vein or a segment 8 vein, we can quickly suture with the robotics much better than laparoscopy. So what are the data we have? Of course, Gilinati group again was the first one to do the right lobe robotic donor hepatectomy in 2012. Subsequently, the first series of 13 robotic donor hepatectomy was done by the Type A group, and they compared it with 15 open donor hepatectomies. And that is a landmark proof of concept study which demonstrated the two groups had similar blood loss, complication rates, and donor recovery time. And then a lot of work was done by Choi group from Korea, Dated Broring from King Faisal. Of course, Troyes is now Dated Broring, and these groups continued to publish a large volume of robotic right lobe hepatectomy, donor hepatectomies, and compared them with open donor hepatectomy as well as with laparoscopic donor hepatectomies. And what they found across all the studies is they have a comparable outcome to open donor hepatectomy without affecting the recipient outcome in terms of biliary complication or vascular complications. And the donor outcome is superior to open donor hepatectomy in terms of hospital stay, number of days of hospital stay, wound complications, pain, and recovery. So what are the prerequisites to establish a minimally donor hepatectomy program? Minimally invasive donor hepatectomy program or a robotic program is the consult surgeon should have extensive experience in open living donor hepatectomy before embarking on robotic procedures. He should have at least completed a large volume of complex hepatobiliary surgeries with robotic approach. A dedicated team of bedside surgeon is crucial because and scrub technicians are crucial because they play an important role in donor hepatectomy surgery. Sometimes we do use QSA, particularly when the anatomy is complex. Collaborative proctorship with high volume centers aids to set up a program with a true smooth transition. It is preferable to begin with donors with standard anatomy, just like a kidney transplant, with a simple standard anatomy. This will enable the feasibility of initial experience and results in good outcome. In fact, dual console training has an important role in development of learning curve, both for kidney, robotic kidney as well as for robotic liver. It is a unique option which allows a proctoring surgeon to guide the procedure, and if something goes wrong, the other surgeon can actually take over if there is a dual console. Just show a quick video of robotic donor hepatectomy. So we basically start with mobilization of the liver. This is a right lobe, right donor hepatectomy for adult LDLT. After mobilization of the, some people go directly to the retroperitoneum and do the retroperitoneum prior to doing the hilum, but we prefer doing the hilum first, do a cholecystectomy, then let's see, retroperitoneal. Then we do the hilum, we isolate the right hepatic artery, we keep to the right of midline. So we loop the right hepatic artery. Once that's done, we go behind and get the right portal vein. And once the right portal vein is isolated, then we give ICG. Of course, we apply bulldogs for the right hepatic artery and right portal vein. We give ICG. We're now doing the retroperitoneal cable dissection. We're just getting some of the small inferior veins. For smaller veins which are under 2 to 3 millimeters, we just directly use a bipolar. For the veins which are a little bigger, we use suture ligation or hemologs and liver clips. And then we pass sling. Once the retroperitoneal dissection is done, we pass a sling and we do a hanging maneuver. Then we give ICG, do a firefly. And that's the right lobe getting marked. And then we start the transection with QSA. Initially, we, of course, we do what this technique, we call this as a rubber band technique. Basically, when we just put sutures to the right and left and pull it across, sometimes it just tears the liver off. So what we do is, and also sometimes we give excessive traction to avoid all these things. We use what is called as rubber band technique. We use this for not just liver surgeries, we use for a lot of other surgeries where the traction is done according to the field. You know, the rubber band itself will relax based on the amount of traction required. We just then gradually transect using harmonics we go to the right of the middle vein, identify the segment 5, then we divide segment 5, and then we continue the transaction until we reach segment 8. And then the segment 8 is divided, they all divided with Hemalox. Once the transaction is completed, we divide the bile duct. Some people use Hemalox for bile ducts, and some now most of the centers now use divide the bile duct and then suture it with 6-OPDS. With the robotics, it's quite easy to suture. Just gonna try and see if I can fast forward a little bit. And once the transaction is completed, that's when we're gonna divide the vessels. That's called as a Goldfinger. We use that to go under the liver on top of the cava to come on the other side of the. Once the hilum is divided, it just helps us to hang the liver and do it. Once the transaction is fully completed, we take out the graft through a fan and stale incision about 8 to 9 centimeters. That's a difference in the cosmetic difference in the scar between the open donor hepatectomy as a routine Makuchi incision versus the robotic donor hepatectomy, where we take out through a small fan and stale incision. Thank you.
Thank you, Swami. That was a very good and excellent videos. I don't think anyone in Australia or New Zealand does robotic transplantation, whether kidneys or liver. So we'll open the house for questions. But my first question to you is, what's the cost difference in both the surgeries, open versus robotic? And in your place, I'm sure the patients bear the cost. But what's the approximate percentage-wise difference for a renal transplant and a robotic donor nephrectomy?
For a robotic kidney transplant, we use about 4 or maybe 5 instruments. Now, with our regular standardization of techniques, now we've come down to 4 instruments. It will come all together, if I had to put it in the US dollars or in Australian dollars, I would say about extra $3,000 to $4,000 just for the equipments. And I would say about 3,000 to 3,500 Australian dollars. And of course, where we win over is the number of days of stay. Now, most of our patients go home on 4th day after a robotic kidney. We take out the catheter on 4th day morning and we send them home by afternoon. So we save a day, basically. The open kidneys go home by 5th day. And by robotic kidney, we send them home by 4th day. Not sure at this stage whether that's going to make a huge cost difference. But yes, 1 day hospital stay is less and the cost is only 3-4 grand over and above.
In your presentation also, I found that you go with a BMI of 40 and over for robotic renal transplants. Is that right?
No, we haven't gone beyond 40 yet, except for one case. We are keeping between mid-30 to 40. It's mainly because we don't want it to, the super obese group it's a bit difficult to do, is what most of the high volume centers recommend. So we've done only 21 so far, maybe now around 23 cases. So the only one case we had a BMI over 40. All others were between 32 to 40 with an average of 35. So that's probably the easiest subset to handle.
Sure. All right. Any other questions?
Hi, it's Jerome here. How are you?
Yeah, hi, good. How are you?
Yeah, good, thanks. I just, I mean, I guess it's not really a question, but more of a statement, which is, we in Australia have a non-commercial transplant sector. In other words, there's the patients for kidney transplants, liver transplants, donor nephrectomy don't pay anything ever, irrespective of their means, actually. And we largely have no competition. So the patients very rarely, if the only reason the patient changes center is because usually they're super high risk, they're on their third, fourth transplant or something, and the initial center has not wanted to proceed. So, and I think, when I look around the world, I think the only thing that I see strongly correlates with the development of movement of robotic surgery into transplantation is a commercial transplant sector, or at least a third-party payer system where there's some sort of incentive to attract cases. Whereas, if you look particularly in, I guess, what are comparable jurisdictions? Australia, New Zealand, the United Kingdom. There's really been no uptake of it, and I think I think the reason is that there's very little return on investment for us. Like we're not going to, the center's not going to gain anything because it'll get the same number of patients. In fact, to be honest with you, the center would probably rather lose the patients because they just cost them money. So yeah, I sort of I don't know how to put that into put that into a meaningful question, but the benefits, as far as I can see, are so marginal. It's very hard in a non-commercial transplant sector where you're not actually competing for the patients to justify robotic surgery in transplantation, I feel, and I think that's the only explanation that I have for the lack of uptake.
Sure.
I beg to differ in that view because, in fact, we don't see a lot of commercial benefit in this one. In fact, the biggest advantage we see here is in obese recipients, where open operation is technically challenging, particularly if you're looking at the wound complication rates, wound infection, the wound pain, and the scar size, the cosmesis. On top of that, with multiple vessels and small vessels, an obese recipient is technically challenging and open when compared to robotic. Only when we do robotic, we understand how easy it is to do a kidney transplant in an obese recipient, and also the precision with multiple vessels. Now that we've started doing multiple vessels regularly, that definitely has an advantage in obese recipients where the depth is eliminated and there is a 10x magnification. Even the small vessels can be implanted very quickly and precisely.
All right. Thanks, Jerome. Henry, you had a question?
Yeah, Henry Pless from Sydney. I mean, congratulations on your work and your presentation. It's great to see things that I won't be doing probably. But I suppose my question really was how you started out and how you selected those kidney recipients. Did you, from your open experience, were they all still transplantable? Because obviously quite often we get patients with a BMI of 36 or 38 that are still transplantable with an open technique, or did you just say, okay, they're not transplantable. If we have a problem, we'll have to, discard the kidney. What was your sort of initial approach? Because obviously you've got a lot of skill now, but did you kind of still ensure that they were transplantable if you had a problem?
Yes, absolutely. Yeah. So as I said, we still kind of keeping ourselves to under 40 BMI. It's just because in worst case scenario, we wanted to open we should be prepared and they should be transplantable. We've been very selective for the first 20 cases. We're now expanding our patient profile. In fact, as we're gaining more experience, our operating time is coming down, and our scrub team, everyone's getting experience. Now we're going to expand our things into a higher BMI. But definitely the advantage is seen in the higher BMI group, because that's where open kidney transplant is going to be challenging, and it's a nightmare for surgeons, obviously. So robotic kidney transplant, certainly we find it exceedingly easy to use in obese recipients.
Sure. Thanks.
Yeah.
Animesh?
I mean, it's a little bit. Oh, sorry. I was just going to have a little follow-on comment that it's sort of disappointing. You've reviewed the literature beautifully for us, but I was really hoping that robotic was going to become the way of transplanting, the morbidly obese with a cadaveric kidney. But you're showing that that's actually not the case, and it's more living donor transplantation, which I can totally see why. But again, it's really following on from Jerome's comment that, I would probably get the sack almost immediately if I suggested doing a 5 or 6 sack kidney transplant starting at 11 p.m. robotically. Do you see what I mean? So I'd probably never be allowed in the hospital again. So you kind of start with living donors. They also tolerate that long warm ischemic time well, don't they? Which I guess is my major concern with this is that long warm ischemic time. So a marginal kidney won't tolerate an hour of warm ischemia, I guess. So until I guess everyone was doing it and we were all a lot faster. I'm sure it'll happen, Swami. It's just how long it's going to take to become standard of practice. Be interesting. You'll be able to see it. You'll be able to tell me when I'm in my grave. You'll be able to tell me.
Absolutely. I was a skeptic when people spoke about robotic kidney transplants in the meetings. Pre-COVID, I was a bit skeptical about, although there was a lot of literature. Then I spent some time with a few surgeons who does regularly, more than 100 robotic kidneys a year. So I went and spent a few days with them, seeing how they're doing it, and then once I started doing it, now actually I would prefer to do robotic kidneys in most of our patients. Whereas our system is driven by finances, so we select our recipients very carefully, and the reason, as you mentioned clearly, for cadaver, it's just that nobody has that energy to do it in the middle of the night. The entire team has to come in, particularly the robotic team has to come in to do a robotic kidney, which is a bit difficult. But actually, that is how it started in most of the programs. They all started with robotic cadaver programs, and then they now moved more towards live donor setting. Okay. And one more point to add to your question of warm ischemia time, the prolonged warm ischemia time. Interestingly, that the Vattikuti technique described by the Vattikuti Medanta technique of regional hypothermia really helps us. We've never had any issue in the live donor setting, because we had on-table urine, we had a creatinine decline comparable to the open kidney transplant, with the postoperative day 4 creatinine of almost 1.2, 1.3 in most of the cases. So the closed abdomen tend to keep the temperature there. It doesn't equilibrate with an open environment, and we keep the gas flow at a lower rate and continue to flush this kidney with saline. So all these things keeps the temperature around 12 to 14 degrees, which gives us an extra 10 minutes to do the anastomosis.
All right, thanks. Any comments, Henry, or should we move to the next question, Animesh?
We better let Animesh. Yeah.
I had a very small question. Thank you, Swami. That was a very interesting talk for me to listen to. It was just about the technical aspect with the creation of the retroperitoneal pocket. Have you, in your experience, had any patients where the kidney had to be positioned in a certain way, or where you had to do an additional maneuver to secure the kidney so it wasn't mobile? Like, was the pocket sometimes too big for the kidney, or did the kidney always remain in that space and not move? Because one of the concerns we often have with intraperitoneal placement of kidneys, as you know, is mobility and the kidney moving around and then causing a kink?
Yeah. So when we started doing it, we did what is called as an open book technique, where I did the vessels first and then did two flaps like a door, and then we positioned the kidney. It's a very tight flap. We just keep the kidney and just put it around. But then we had one patient had a page kidney. We had to explore the next day. That was probably because of the handling of the kidney as well. Now what I do is completely drop down the parietal peritoneum, like how we do for a robotic tap, like a hernia repair. So I do from at the level of umbilicus, I go down all the way to the iliac vessels, bring it medially, and then implant the kidney, and then just drape over the flap and just suture it with V-lock sutures. Now it just goes completely extraperitoneal. The kidney goes extraperitoneal completely. So this is like pretty much doing standard extraperitoneal open kidney transplant, and we never had any issues with that. And that was developed by one of the surgeons, Kishore. That is a technique developed by him to do that full flap. Yeah, and we never had much of an issue.
Okay, all right, that's very good. Any other questions? All right, thanks, Swami. It was indeed a very good talk, but I really don't know in countries like where we are, Australia, New Zealand, it is, I think, a bit difficult to do robotic transplantations. But hopefully, one fine day we'll have good evidence and robots will be much cheaper, and maybe we all will take over that technique. But we'd like to hear in future from you about your experience in high BMI patients, if that is feasible and easy to do. Maybe that may be an indication to do. All right.
Thank you, Mayank. Thank you for having me. Thank you, everyone.
Thank you, really. Thanks. Bye.
Yeah, many congratulations, Swami. Yeah,
Thank you.
Pretty impressive. Very
Thank
good.
you. Yeah, thanks.
Thanks. Bye.
Bye.
Thank you, everyone. Thanks.
Bye, everyone.
Bye.